Everyone, I would like to invite a brother, a friend, and a colleague, Dr. MAen Al MAttooq, who's a consultant gastroenterologist and transplant hepatologist at Jabr Al Ahmed Hospital here in Kuwait. Received his undergraduate degree from Royal College of Surgeons in Ireland, completed his medical residency and GI fellowship at King Khalid University Hospital and King Faisal Specialist Hospital. Obtained his hepatology fellowship from University of Calgary and University of Alberta in Canada. Dr. MAen.
Assalamu alaikum. Thank you, everybody. Good morning, ladies and gentlemen. First of all, I would like to thank the organizing committee, Dr. Ahiba, Dr. Mohammed Malik, Dr. Shaib, for organizing such wonderful meeting. And it's an honor to be back and to present in KGA. So today, our talk is about the management of muscle in primary care setting. Initially, I had an objection about the title, and then when we started our campaign and study, it's a multinational, multi-center study where we are studying the prevalence of fatty liver and the characteristic of fatty liver in the Middle East and Egypt. Multiple countries with us in this study: Egypt, Emirates, Kuwait, Saudi Arabia. So this is like big study going on. We are in the recruitment phase now. We started it 2 weeks back. We are targeting Kuwaiti population from the age of 12 to 70 to know the prevalence of fatty liver. It will be, inshallah, the first study that will be soon published at the end of this year, hopefully. So when we started our study, I realized that many of the family physicians, they don't know when to refer, how they screen, and when to screen for fatty liver. So this is a great opportunity to set the stage. So I have no disclosure. My overview today will go about the definition and subclassification of steatotic liver disease. We'll go briefly about the epidemiology, the growing burden of muscle, MASH, when to screen and how to screen, treatment in 2025. This is what the liver looks like on the ultrasound in patients who have fatty liver. It's enlarged, increased echogenicity of the liver, and diffuse steatosis. So I know that this is very heavy slide, but if we can start on the left side, this is the cardiometabolic risk factor. So if the patient have at least 1 out of 5 cardiometabolic risk factor, then he's satisfied to diagnose of muscle. So we have to have 1 out of 5 cardiometabolic risk factor. We have to have overweight, BMI equal more than 25, or waist circumference in male more than 94, and female more than 80. Patient diabetic, or have impaired diabetes or pre-diabetes with fasting blood sugar equal more than 5.6. HbA1c equal more than 5.7. The third criteria, patient is hypertensive or have blood pressure more than or equal 130/85. The fourth criteria, patient is dyslipidemic or having plasma triglyceride equal more than 1.7. The fifth criteria, patient is dyslipidemic as well or having serum HDL equal more than less than 1 in male or less than 1.3 in female. So if we start on the top of the algorithm, steatotic liver disease is defined where there is a presence of hepatic steatosis in imaging or in liver biopsy. So for a patient to diagnose him with MUSCLed or MASH, patient should have evidence of steatotic liver disease, an ultrasound or in biopsy. Number 2, he should have at least 1 of the cardiometabolic risk factor. And third criteria, he should drink the safe limit of alcohol. The safe limit of alcohol defined as less than 20 grams in female, this is like 2 glasses of wine per day, or less than 30 grams per day in male. So if we have these 3 criteria, then the patient having MUSCLed. If there is element of inflammation in biopsy, then we can diagnose him as MASH. If the patient have evidence of steatosis and have at least 1 cardiometabolic risk factor and have modest drinking, this is defined as 20 to 50 in female, 30 to 60 in male, then patient this having like combination of metabolic and ALD, what we call it MET-ALD. If the patient have evidence of septic liver disease and at least one cardiometabolic risk factor, but he has significant drinking of alcohol, then we can label him as ALD, not MASH. On the other hand, on the far end algorithm, if the patient have steatotic liver disease and no cardiometabolic risk factor, you have to think of other etiology like drug, cryptogenic, SLD. So we know that MASLD or MASH is a global health problem and it's increasing worldwide. And this is the prevalence of MASH in 2016 by Yanussi and his colleagues that was published in Hepatology Journal in 2016. You can see the prevalence in Middle East is around 31%. If you compare this graph with the latest data that was published by Yanussi as well in Hepatology Journal to 2023, we are sitting at the 40 to 45% prevalence in Middle East. So there is like 15% increase over the last 7 years. How about diabetes type 2? Definitely, also the prevalence is increasing significantly. At least 70% of diabetic patient type 2 have fatty liver, and also definitely it's increasing with time. We are reaching now almost 70% in 2021. We know that the natural history of MASLD or MASH is a silent progressive disease. Patients who have NAFLD, at least 40 to 60% of them will progress to MASH over 3 to 7 years, and some around of 20% they will progress to advanced fibrosis and cirrhosis over 4 years. Patients who have MASH, they will progress around 20%, they will progress over 7 years to advanced fibrosis and cirrhosis. And patients who have advanced fibrosis or cirrhosis, at least 10% of them will have an HCC over 3 to 7 years. That's why we do screen our patients who have advanced fibrosis and cirrhosis with an HCC, with an ultrasound and alpha-fetoprotein every 6 months. There are other well-identified criteria in the guideline which can expedite this pathway, and they have higher risk of HCC. Those are patients who have diabetes type 2 presence, and the duration of, especially if diabetes is prolonged and uncontrolled, older age, concurrent use of alcohol, an individual with Fib more than 3.24, individual with FibroScan of more than 10 kilopascal. The pathogenesis is very complex, and this picture beautifully demonstrating the complexity of the pathogenesis. We know now there are multiple genes involved in MASH, MASLD, in terms of etiology. The well-identified gene is PMPLA3. On the other hand, in the other left corner, also there is diet, unhealthy diet, which contain of high fat, high sugar diet. Also, we have low physical activity. Don't forget that there is also an element of lipotoxicity, oxidative stress, and altered microbiota. All of these can alter and change the pathway and the pathogenesis of MASH and MASLD. Eventually, we'll have insulin resistance, which is the underlying mechanism of progression of MASH MASLD. Also, they will have a higher risk of cardiovascular disease. At the end, the pathogenesis will lead to liver cell failure and the major adverse liver event. So how do we screen? Dr. Munira make my life easy. So we have FIB4 score. I think everybody now should be familiar with FIB4 score. You can download the app in your Android and your iPhone, and you should start calculating your FIB4 score. If the FIB4 score is below 1.3, this is low risk. Just repeat again after 1 year and reassess your patient. If your FIB4 score more than 2.67, you should refer him to the hepatology for other assessment and other imaging. So this is the algorithm that has been recommended by the INT'L guideline in 2024, as well as ACE guideline, the American Association of Clinical Endocrinology. Also, they provoked and recommend the same algorithm. So basically, if you can go through the algorithm, if you have a patient who have diabetes type 2 or obesity and at least one of the cardiometabolic risk factor or presence of or persistent elevated liver enzyme, you should do your FIB-4 score. If the FIB-4 score is below 1.3, then reassess your patient after 1 to 3 years. If the FIB-4 score is intermediate risk, that means is 1.3 to 2.67, then you have two options. Option B, intensify your management and reassess his FIB-4 score within 6 months to 1 year. Option A, refer the patient to us for FibroScan. If the FibroScan is below 8, we'll refer him back to you. If the FibroScan is equal more than 8, we'll do our further imaging and further assessment to predict what's his fibrosis stage. As I said, this is the ACE guideline. In association with the ASLD guideline, recommend the same algorithm. We have non-invasive, as Dr. Munira said, way of assessing the fibrosis in patients who have fatty liver. We have on the left the FibroScan, the 2D share wave, and on the far left end we have the MRI. So why do we care about fibrosis stage in patients who have MASLD or MASH? This is very crucial to know where we stand in terms of stage of fibrosis, because multiple studies shows that the single factor that associated with worse prognosis and increased mortality in patients who have fatty liver is the fibrosis stage. And this clearly demonstration here, if the patient progress from F1 to F4, they will have higher risk of the major adverse liver event, cirrhosis, liver cell failure, and HCC. That's why we need to catch the patient early in screening and in terms of diagnosis. Also, Hagström and his colleagues beautifully demonstrate by the Kaplan-Meier and his study that was published in Hepatology Journal in 2017 that patients who have FIB-4 score, have the advanced fibrosis, F4 stage of 4, they have worse prognosis and higher mortality than patients who have F0 or F1. So now I will go with the treatment of MASLD in 2025, where we stand and what's the recommendation. So I believe there are three factors which are playing the risk of progression of fatty liver and can expedite the risk is the sedentary behavior, low physical activity, especially in our community, poor diet, high sugar, high fructose, high fat, and also alcohol consumption. All these can worsen the pathway, can expedite the pathway to have advanced fibrosis. So if you can target in your clinic, my advice is to target and advise the patient to do an exercise at least 5 times per week, 30 minutes of aerobic and exercise. Always focus on treating their underlying risk factor, like diabetes, hyperlipidemia, smoking, alcohol. Always address these factors as you can minimize the risk of progression. And always I notice in the clinic that the family physician or the internist, they are reluctant to start a statin once they see the ALT is upper limit of normal in patients who have fatty liver. So don't worry about the statin. The risk of statin-induced hepatotoxicity is very, very low. You can safely start statin and you can monitor their liver enzyme within 2 weeks to 4 weeks after starting statin. Avoid alcohol, stop smoking, address their weight, exercise, address their BMI, and manage aggressively their diabetes. So what diet we have and what diet has been recommended in the guideline, the same. We have had the hypocaloric, the Mediterranean diet, which consists of low calories diet, olive oil, fish, vegetables. This is typically against the Western diet, which has been shown clearly that can progress fatty liver and can worsen the steatosis, especially with high sugar, high fructose, high carbs diet. In terms of exercise, as I said, the most studied exercise is the aerobic exercise and resistant exercise. We advise to do at least 5 times per week, 30 minutes. in each session. This has been clearly shown with a weight loss of 10% can reverse fibrosis in up to 80% of our patient. So the recommendation in the INT'L guideline 2024, just to summarize it, on the left, patients who have muscle and overweight, the recommendation, especially if they have fibrosis, is to lose 7 to 10% of their weight for fibrosis reduction. If they have only steatosis, 5% of their weight is enough. If the patient have muscle and obesity class 2 or 3, always think of your GLB, Mounjaro, Ozempic, and your bariatric. This is my advice, and the INT'L advice. On the left hand, as again, what I have been talking about in the previous slide, they do recommend the Mediterranean diet, the hypocaloric diet, and the exercise at least 30 minutes a session, 5 times per week. So this is their recommendation, and this is their algorithm. For MASH-related F2 fibrosis or advanced fibrosis, they do recommend to start resmetirom, the Rezdiffra, the new treatment. If the patient have advanced cirrhosis or decompensation, always think of liver transplantation. And patients who have diabetes type 2 and have MASH muscle, always the recommendation is to go with the GLB, the nicotine analog, the GLB1 or /GIB analog, the Mounjaro or Ozempic. The second recommendation is in patients who have diabetes is the SGL2 inhibitors, metformin, and in case of decompensation, give insulin. Dyslipidemia, statin. For obese, again, GLB1 analog, either Mounjaro or Ozempic. Or in patients who have morbid obesity, go with your bariatric surgery, and advised early pediatric surgery in certain population who have well-compensated cirrhosis, child A cirrhosis. The recommendation is to go with bariatric surgery. This is our new treatment, the first targeted therapy, which is the beta-selective thyroid hormone receptor analog, resmetirom, Rezdiffra. The problem with Rezdiffra is expensive. It's not available yet in our country. We are expecting it in 2026 based on the company that we spoke to in an ASLD. So we have 3 doses based on the weight of the patient. Above 100 milligram, we give 100 milligram per day, 1 tablet. Patient who's below 100 milligram, 100 kg, we give 80 milligram once daily. The 60 milligram is produced for patient who's on clopidogrel, Plavix, because there is major interaction with clopidogrel. So the recommendation to give 60 milligram. Also, the patient who's taking this cytochrome B2C8, also the recommendation is to give 60 milligram. So this is the landmark trial on which the resmetirom is approved. It's one of the randomized control, placebo-controlled trial, multi-center, that was published in the New England Journal of Medicine in February 2024. The aim of the study to study the safety and efficacy of resmetirom in significant fibrosis F2 and advanced fibrosis F3 based on liver biopsy. The study recruited almost 1,000 patients. They divide the patient onto 3 arms, 100 milligram, 80 milligram, and placebo. And the primary endpoint is the NASH resolution without worsening of fibrosis. The secondary endpoint is the improvement of fibrosis by 1 stage or more without worsening of NASH. And they find that after 52 weeks of follow-up and the biopsy initially and the biopsy at the end of 52 weeks, they found that at least patients who receive 100 milligram, they have 30% NASH resolution, and 26% they have NASH resolution in patients who receive 80 milligram. In terms of fibrosis improvement, patients who received 100 milligram, they have 26% fibrosis improvement, and patients who receive an 80 milligram, 24% they have fibrosis improvement. So where do we stand now from the treatment of muscle and MASH? We do learn from our previous failed medication and many withdrawn drugs. That's why now the drugs that making revolution in the field of MASH and muscle. This is the incretin mimetics. We have like at least 3 of them now. Mounjaro, which is the dual GLB1 receptor analog and GIP analog. Mounjaro, it has been studied extensively in the Synergy trial, which shows at least reduction in 50% of fibrosis. The second incretin mimetics, the survodutide, is still in the phase 2 trial. It's also dual agonist. The third one, the one I think will make revolution, and it will beat bariatric surgery, the triple analog, the retatrutide, still in phase 2 trial. So the trial that we have, and we have good evidence now on Ozempic, good evidence on Mounjaro, and also the coming one, survodutide. On Ozempic, we have the late breaker, which was presented last year in AASLD, the Essence trial that was published in December 2024. Ozempic shows at least MASH resolution in 63% at 72 weeks. We have fibrosis improvement in 37% of patients at 72 weeks. In Mounjaro, we have the Synergy trial that was published in July 2024. We have 62% of patients achieve MASH resolution, and at least 51% of patients achieve fibrosis improvement by 1 stage at 52 weeks, which is really good result. The survodutide, it's still in the phase 2 trial. It was published in July 2024. It shows also 62% MASH resolution, and 36% of patients, they achieve fibrosis improvement at 48 weeks.
Man.
This is last slide.
Perfect.
So in summary, from this presentation, and my advice is always target your patient in terms of obesity. Don't wait on them. Target the lifestyle, diet, exercise. In patients who have obesity class 2 or morbid obesity, always recommend GLB, bariatric, especially if they have advanced fibrosis and certain population of cirrhosis in child A. Always target their metabolic risk factor, diabetes, hyperlipidemia, and hypertension. Third, also, if the resmetirom available, which is the first targeted therapy, we can give resmetirom to F2, F3 fibrosis, and always minimize and try to downstream the complication and always screen for your HCC in cirrhotic patient.